the cells into the posterior annulus, you have to fill the hole. Otherwise, the cells are going to fall back out. How do you do that? You do a blood patch. Finally, you have to provide fertilizer. So at week 2 and 4, we provided epidural injections of vascular endothelial growth factor rich supernatant. Here's a fluoroscopic view of the lumbosacral spine, and this is part of the pattern that was demonstrated in one of our patients. I've outlined it. We had both annular flow as well as flow into the nucleus. So what about the results? Well, here we are. On the left, this is an axial cut. You can see the red arrow depicting a little bit of a bulge. Well, that little bit of a bulge was also creating radiculopathy or leg pain in this patient. 4 weeks later, there's a significant reduction in the size. This correlated with a clinical response. Here's a sagittal picture. You can see this protrusion outlined in red. This is the L5S1, which is still protruding, but to a much less extent at 4 weeks. Here's another picture. Pre-op, 0.5 centimeter protrusion right here. 1 month later, it went from 0.7 to 0.3. 5 months later, it was still the same. The patient was 75 to 80% better. The study demonstrated that utilizing autologous mesenchymal stem cells that had been expanded, put in the posterior annulus, and then provided nutrients in the way of vascular endothelial growth factor, we were successful in decreasing the protrusion and increasing the function in 2/3 of our patients. Why did this happen? Koga very eloquently demonstrates placement is everything. You can place cells, and he did. He's demonstrated by placing cells at random into a joint versus specifically targeting the defect. We also feel it's essential to put the cells in the posterior annulus as opposed to the hostile environment in the nucleus. Unfortunately, those tools for the exact placement, which is essential for success, aren't available. So these were our goals at the end of that study: to deploy mesenchymal stem cells into the posterior annulus at the level of the injury. There wasn't a steerable catheter available, nor was there an atraumatic approach to the annulus until now. This is a new needle which allows us to overcome both those hurdles. This is a patent-pending needle. It uses a 20-gauge Sprott. They spelled it wrong. It has a nitinol curved second needle, and through a third catheter, which is very small, in the magnitude of 200 nanograms, you are able to deploy this first needle and then this second needle, and I'll show you in the next picture. But it's for the first time ever that we have a steerable catheter to successfully place cells at the site of injury. Here's another picture. Here's the housing. Here's the needle. You deploy the nitinol guide cannula to the right trajectory, followed by advancing the very thin-walled catheter, and you go into the nucleus, just like with a discogram. You deploy the cannula, and then you come back to the annulus. You confirm your placement, and then you're able to deploy cells. Thank you very much for your time. We're from Colorado. We've got lots of things to do in the winter. We've got lots of exciting things to do. And I want to thank you all for taking the time out of your family life to come and listen to us. Uh,
I noticed that you didn't have a neural following the procedure.
correct.
Did it transcribe on the same level again? Yes.
The one below. Let me answer the first question. And I didn't get into this for sake of brevity. The disc that was treated was identified as the symptomatic disc either by provocative discography or highly selective low-volume select nerve root injections. So we first had to do some diagnostics in those patients, like the patient that you saw that had two-level disc disease. Second question was we did an epidural post insertion or deployment of cells. That was a blood patch to ensure the adequate placement of the cells and to ensure that they didn't flow back. This was a very small study. There will be another one forthcoming. Good question. Thank you. Yes?
How do you know that this disc would not have resorbed by the cells without inhibition? Because most of the time they do. Unless you do a double blind study, you don't know.
Yeah. Very good question. Did everyone hear it? The question was how do you know the outcome of the disc, given that there is some natural history that the disc will heal on its own? In this particular case, in several cases that we've seen, there has been no change in two-level disc disease in the untreated disc. That's to say, if it was going to heal on its own, it would, but it didn't. Is that clear? So at the L4-5 there on that one patient, there was two-level disc disease. There was a reduction in the disc protrusion at L5-S1 from 0.7 centimeters to 0.3. There was the same reduction in disc protrusion was not appreciated at the control level.
How long did these patients have been?
That was the other part of the criteria. They had to have failed all conservative therapies, and on average, they were 1 to 1.5 years out in terms of their pain.
Yeah, two things here. One is annular repair, and the other is nucleus regeneration. And what it looks like what you've done here is repair the annulus so that you're tightening up the annulus, maybe increasing the thickness of the annular fibers, thus the protrusion decreases. Now, the other part of the question is, did you have any nuclear repair, increased nuclear material, dark turning white or anything like that?
Great question, and I'm glad you brought that up. We believe that the annulus is a vascular tissue and therefore amenable to repair. Hence the reduction in disc protrusion as depicted. But equally important, and I didn't share that with you all, we have seen a change in the signal. That's to say, where the previous L5-S1 disc was dark, it's no longer holding on to water. In two of our patients, there's been a change in the quality of that picture after mesenchymal stem cell implantation, such that they started to hold on to water again. So we push that out and believe that there has been some regeneration of the nucleus. Great question. The question was, could we take nuclear material and implant it? It's a great question. That's something we haven't done to date, nor do we intend to do it in the immediate short term. But
Let me just take one more question because I want to get the next speaker on.
I just wanted to get your protocol on those activation of the platelets. How do you do the activation of the platelets?
Yeah, the paper is by Martineau in terms of activation. It's if you go to PubMed, or if you see me afterwards, I'll be happy to share it with you. Thank you very much.
Okay, thank you.